All right, well, the recording's in progress in case anybody wondered. All right. So we're going to go through about 14 or 15 questions that I think will be high yield for you for topics for boards. Before we get started on the pulmonary specific stuff, let me just give you my own personal 2 cents on board prep. Do as many questions as you can from as many sources as you can. So prep is going to have really long stems, much longer than the actual board test. Med study is stems are much more like the boards, but I think a little bit harder than actual boards. So do a combination of both. If you're finding that there's topics that you're missing over and over, focus on those topics. Don't spend hours on the stuff that you know really well, even though you probably enjoy studying that, because you're going to get those questions right on boards. But do lots of questions and remind yourself over and over to not put things into the question that they're not actually asking. So answer the question that they ask and don't try to be like, well, I think they were thinking X, Y, or Z if there's no proof for that in the STEM. So that's my just general. Nope, I did them all together because I didn't want to be skewed by knowing I was doing a certain question type. So yeah, I did not break them up. I did do that though with the flashcards and did the flat med study flashcards in the specific areas that I knew my scores were lower. So if I had like rheumatology, for instance, we didn't have room when I was here. So that was a weaker area. So I did a lot of room flashcards. So whatever area you know, or genetics or something, whatever you know is going to be harder for you. That's kind of what I honed in on. So yes. Okay. So let's get started. So on general peds boards, pulmonary is going to be about 5% of the overall test. And they are going to pull from any number of areas within pulmonary medicine. Unfortunately, now, if you look at the breakdown of what's on the test, they no longer give you like really specific diseases or whatever. They give you these really broad upper airway, lower airway, parenchymal. So basically know everything is what they end up saying now. But it's only about 5% of the test, which is a decent chunk. And they'll cover a broad range of topics. These questions that I'm pulling from are somewhat from some of the prep questions about 5 to 7 years ago. But I'm trying to cover most of these topics today. So first of all, you need to know asthma. You really need to know it inside and out. They're going to ask you several questions on the test about asthma. And you guys have seen a lot of it. You see it in clinic. If you've rotated with us, you've seen it. If you haven't rotated with us, the one thing you might not feel super comfortable on is pulmonary function testing, and they might ask you questions about spirometry on the exam. So if you have questions, let me know. You can always email me when you're studying for boards. If you have questions about something you've come across with this stuff, shoot me an email. But definitely know the general parameters of spirometry. So for asthma, you typically are looking at symptoms that start about a year of age. Some kids who have prematurity, strong family history, you're going to see symptoms before that. If you've got a kid that gets a bad RSV infection, you might see symptoms before that. But traditionally for the test, typically around a year of age. Nighttime cough and cough with exercise are 2 things that might pop up on the question stems. The actual definition of asthma includes reversibility of the obstruction on spirometry. And like it says here, you should see obstruction on their PFPs. So there's been several iterations of the National Heart, Lung, and Blood Institute asthma guidelines, and they just recently came out with some new guidelines last year. I do not think that those changes are going to end up on your board exam. Usually takes several years for those things to show up on boards. The biggest change, just so you know, is that there is now an allowance for using a combination inhaler as a rescue for patients who are on Dulera or Symbicort. You cannot use it with Advair because salmeterol is not fast acting, so you cannot use it as a rescue medicine. But Dulera and Symbicort both have formoterol, which is fast acting. So now the guidelines, both the GINA guidelines and the NHLBI guidelines, and they say for 12 and above, but really practically you could use it for younger kids. You can use it as a rescue. But like I said, you're probably not going to see this in your board questions. So have a general familiarity with these charts, and remember that there's two. There is a severity chart and a control chart. They look very similar, but they are not the same. You want to have a general understanding of where intermittent, mild, moderate, and severe ranges. They're not going to ask you to differentiate between moderate and severe. Okay, it's going to be, do you understand what a mild intermittent is? Do you know what a severe is? So have a basic understanding of these charts. Know that an FEV1 less than 80% is abnormal. I don't think they're going to ask you nitpicky things about the ratios, but we'll talk about that in a minute. And then understand that frequent steroid use is a sign of poor control. Again, you can get all of these charts very easily on the NHLBI website. So if you really wanted to look closely at them, they're easy to find. But overall, if patients are doing well, they're typically having symptoms less than 2 days out of the week. They're not using their albuterol frequently, and they're not getting frequent steroids. So this is the control chart. And you can see they've got well-controlled, not well-controlled, very poorly controlled. And these aren't, in reality, we don't use these black and white, but for the test, have a general idea of frequent nighttime cough, frequent use of albuterol, a low score on your asthma control test are all indications of poor asthma control. So you'll see here where it says lung function. Let's see if I can you see my pointer? You cannot see my pointer. Okay. So if you see on the left where under lung function, it has FEV1, and then it has a ratio in the next row underneath, FEV1/FVC. So that is another indication of obstruction. And they're considered well controlled if that ratio is greater than 80%. So just kind of think 80%. If you rotate through with me, I will tell you the American Thoracic Society guidelines actually say 90%, but for the test, 80% for FEV1, 80% for the ratio is normal. And then have some familiarity with this chart and how to step up therapy for asthma, which you guys do all the time in CHOC. So know that if you step up from a low dose inhaled corticosteroid, that you can go to either a medium dose inhaled corticosteroid or a combination inhaler. Again, for practicality, most of the studies have shown better response if you step up to a combo versus just stepping up the dose of the steroid. But based on the guidelines, you can do either. Either is considered appropriate. And then continuing to step up from there. So if they ask you about asthma exacerbations, you're talking about steroids at 1 to 2 mg per kg per day, which you guys already do. You know your options include continuous albuterol, terbutaline. They're probably not going to get into the weeds too much with treating status asthmaticus, but do know if they give you a blood cast on a kid with asthma who's coming in through the ER, that a normal CO2 is not good, because they should be tachypnic and blowing off their CO2 and have a low CO2. So you're actually heading towards respiratory failure if you've got a bad asthmatic who is really tight and his CO2 is normal. Okay, so let's go through some questions now that we've done a quick asthma review. So we'll start with those of you in the room live. Let's read through the questions, and then I would like somebody to at least give me a guess. So you've got a 3-day-old newborn with a long, narrow thorax with short ribs and short limbs. She's diagnosed with asphyxiating thoracic dystrophy, also called June syndrome, by genetics. Vital signs are normal. Breathing is fast and shallow. During inspiration, she has an exaggerated paradoxical breathing in which her abdomen protrudes out while her chest moves in. Good air exchange, no wheezing or crackles. How would you best describe her respiratory pathophysiology? E. Okay. Anybody else? Any ideas? D, increased lung dynamics. Let's look at this then. Answer is C. So let me show you a chart that is very easily Googleable. So if you want it to study off of, you can. So this is a graphical representation of the different volumes and capacities that we look at with the lung. So if a child has June syndrome, so they have a narrow thorax, which means the overall lung capacity is reduced. Everything is squished down. So if you look at this chart and you just compress it vertically, everything gets smaller. So that is essentially what happens in this kid. They're trapped, their lungs are trapped in a tiny box that doesn't move very well. So if you go back, decrease forced expiratory volume in 1 second. So that is your FEV1, and that is what you're going to see is decrease in obstruction. And this kid is severely restricted. Decreased lung elastance really is about the fibers in the parenchyma of the lung. So we're looking at the actual structure of the ribs that's impeding on lung expansion. So total lung capacity, if you go back here, is the arrow that runs from the top to the bottom line. So in restriction, everything is compressed down. So your total lung capacity overall is smaller. So that is the volume that, or the capacity is going to be smaller. Dynamic lung compliance, again, has to do with change in volume for change in pressure. That's more about the properties of the lung parenchyma itself. And so we're not necessarily looking at problems with the lung tissue, we're looking at problems with the chest wall. And then E is increased functional residual capacity. So, and that you might see in a patient that has a lot of air trapping, but that's not going to be increased in this case, because remember I said everything is compressed down. So all the other questions are incorrect for those reasons. Does that make sense, thinking about lung capacity? Okay. Well, if you go back to the STEM, it was trying to kind of give you some of the understanding, yeah, with the narrow thorax, the short ribs, the paradoxical breathing. So yeah, you don't, if you had seen a June syndrome kid, it would be much easier to answer this question, but you can infer some of those other things from the so this is just a little bit more looking at pulmonary function testing. So the graph on the far left shows what a normal expiratory curve would look like, not necessarily what you'd see on spirometry, but the area under the curve is FVC, so your forced vital capacity. And that arrow where it says FEV1, that's the volume that you are expiring in the first 1 second. And that's a hard and fast expiration. So with a normal patient, you would see this full FVC area under the curve with that FEV1 is the area under the curve up into that line. So with the restrictive pattern in the middle, you see everything is squished. So everything is smaller. And then with obstruction, the third picture there, you see that everything is down a little bit as far as not getting out as much air in that first 1 second, but much more closer to normal FVC. So not decreased as much as in restriction, and your ratio of your FEV1 to your FVC also is different. So that's what we're going to talk about in this picture on the right. So with obstruction, everything is a little bit lower, which I know is kind of counterintuitive to what I was just saying about all the capacities and the volumes being squished in restriction. But what happens is that in obstruction, your FEV1 is down and your FVC is down, but not in the same ratio. So your FVC is going to be down a little bit only because that FEV1 component is down. But your FVC is much closer to normal. In restriction, everything is low because everything is squished down. But the ratio is normal because everything has come down in relation to each other. So if you put FEV1 over FVC and they both are completely squished down, you're going to have a normal ratio. But if you have pretty normal vital capacity, but only the FEV1 component is down, you're going to have a lower ratio. Does that make sense? It's a lot of math. If you can think through the math, then it makes a lot more sense of why you would have a normal ratio in restriction and a low ratio in obstruction. So your FEV1 is decreased out of proportion to your FVC in obstruction. Everything is down in proportion in restriction. If you're still struggling with that concept, let me know. It's not going to be a huge proportion of this test, so you don't need to spend hours and hours trying to understand it. But if you're confused, let me know. Okay, second question, and I would like a answer from clinic from this one. So 1-year-old infant brought to your office for evaluation. Parents state that the infant was born with asthma, noted to have wheezing for the past year, once to multiple times a day. The wheezing is occasionally related to exertion and to a full feed. He's been prescribed 2 puffs of a short-acting beta agonist with a spacer, and it only seems to help when he has a cold. He was noted to spit up when he was younger, but that's improved. Never gotten steroids, height and weight are 50th percentile, normal exam. Of the following, and remember, we're only asking about what's listed here. Of the following, what's the most appropriate test to order? So clinic, I give you about 30 seconds to give me what you guys think the answer is.
So we were thinking an echo for like an underlying heart thing.
Okay, what underlying heart thing are you thinking about?
Like right-sided obstruction or something that would back up into the lungs.
Okay. Would a right side obstruction back up into the lungs?
Something causing right heart dysfunction. That's what
Okay.
I
Okay. Okay. All right. So the answer to this question is B. I think this is a hard question. And you will see some tricky ones like this on the test. So this patient may have an anatomic anomaly with some kind of abnormal vasculature. We know that the best test for that is probably a CTA, but you can see some compression anterior or posterior of the esophagus on a barium swallow that can nudge you in the direction of what vascular anomaly might be there. So I like that clinic was thinking about the heart, but unlikely to have wheezing with something that's causing right-sided dysfunction. So that is more likely going to be something like pulmonary hypertension that would be causing right heart dysfunction. The other thing is the nature of the wheeze. If it is a fixed monophonic wheeze, then you're thinking about a structural issue that is compressing the airway and isn't dynamic and changing. It can be a little bit difficult to determine when you're listening whether you think it's monophonic or polyphonic. But if you're hearing the same sound over and over and over, and you're seeing this patient and they're well, and they're making the sound, you have to wonder about an anatomic issue. And so from this particular list of tests, the most likely one that's going to give you that answer is the barium swallow. Any questions about that one? Is Ward's on? Yes. So Wards, if you're listening, I'd like an answer from you guys on this one. So question 3, 17-year-old adolescent who is an elite level soccer player presents for evaluation of dyspnea and a feeling of throat tightening with exercise. Symptoms resolve within 3 to 5 minutes of exercise cessation. Mom relates that her previous physician treated her with inhaled albuterol and then subsequently prescribed Singulair and an inhaled steroid. No improvement on those meds. Otherwise healthy. No symptoms when she's at rest. Normal exam. What's most likely to improve her symptoms? All right, wards, you have about 30 seconds.
I have to go with additional athletic training.
Okay, what do you think her diagnosis is?
That we're not quite sure, but
Okay, all right, that's all right.
yeah.
It's
So-
vocal cord dysfunction.
Correct. She has vocal cord dysfunction. So that is typically treated with speech therapy. So there are abdominal breathing exercises that can help with this to help them learn to actually relax the muscles around the vocal cords. Very common in adolescent females, very common in high performing athletes and high performing students. So this is much more common than you realize, and speech therapy is the treatment of choice. Some of these patients, you may not see this on boards, but some of these patients who have a little bit of exercise-induced bronchospasm too may respond better to Atrovent than albuterol. So just a little nugget to keep in the back of your mind. But yeah, speech therapy is the way to go with these kids. And there are some speech therapists out there trained to deal with vocal cord dysfunction. We don't have anybody really great in the area here, but there are some across the country that are good at this. Okay, so looking back over the questions that we just did, some of these are considered asthma mimics. So people who wheeze don't necessarily have asthma. So you need to look at the age, other things in their history. So someone who's had a prolonged intubation could have some issues with the vocal cords. Older child with symptoms like this last patient, when they do PFTs, if they are actively having vocal cord dysfunction, you will see the inspiratory loop, instead of being nice and rounded, will be flattened. So that's another thing to look at if you have spirometry in your office. A lot of times we have to get these kids on a treadmill and push them before we can actually see that on spirometry. The other thing that can be really helpful is to run them on a treadmill until they're symptomatic and then actually do a laryngoscope right there as they come off the treadmill. And sometimes you can see the vocal cord spasming on the screen, and that can be really helpful for families to see too. So other things to consider, and some of you have seen the patients that I brought in for inhaled lidocaine, but habit cough, really harsh, brassy cough that doesn't respond to anything, that goes away when they are distracted or asleep. Definitely consider habit cough or tick cough. Usually tends to be triggered by a viral infection, and so they just kind of got in this mental loop of needing to cough. It's not behavioral. You can't punish them out of it. You can kind of redirect them, but you really have to retrain their mind. And so I talk to parents a lot about small sips of room temperature water, trying to distract them, finding ways to kind of redirect those neuronal pathways from continuing to cough. And then always, if you have a sudden onset of wheeze in a young child, consider a foreign body. So this is kind of our asthma differential for patients who are not sure whether it's asthma or not. And you can see vascular anomalies like we talked about with that first baby is on the list. Okay, next question from the peanut gallery here in person. 15-year-old adolescent brought in with a complaint of cough for as long as he can remember. He's been treated with antibiotics for bronchitis and systemic steroids, inhaled steroids, short-acting beta agonists. For asthma without reported improvement. Cough is wet and productive of green sputum. Moderately short of breath with exertion. He's had poor weight gain with malodorous stools and been frustrated by his inability to gain muscle mass. No history of recurrent ear or sinus infections, born term. Thin adolescent male and no distress. Normal respiratory rate. Lungs have bilateral and diffuse crackles without wheezing. Chest x-ray shows diffuse bilateral increase in interstitial markings with peribronchial thickening. No focal infiltrate or effusion. Pulmonary function testing shows a moderate obstructive defect with an FEV1 of 58%. And he has this CT scan. I'll give you guys a second to look at it. All right. So what's the most likely etiology? Alpha-1 antitrypsin, CF, hypogammaglobulinemia, Cartaginer syndrome, or sarcoid? Yeah. This kiddo has CF. And if you look back at his CT scan, you can definitely see bronchiectasis. In the right lobe, on the left side of your screen, you actually see kind of some train tracking longitudinal bronchiectasis. You also can see a couple of the airways that are enlarged. And the way you know they're enlarged is you want to compare them to the accompanying blood vessel. So if they are larger than the blood vessel next to them, then that's considered abnormal size and would be consistent with bronchiectasis. So you guys know a lot about this. We won't belabor CF too much, but know that it's the most common recessive disease with Caucasians. It is caused by a mutation in CFTR. It affects more than the lungs, also GI and liver. Gold standard is still sweat testing. And on exam, you may see failure to thrive, might hear crackles, and may see recurrent pneumonias. So we actually sweat quite a few kids that come through with recurrent wet cough or recurrent pneumonia. Remember, the newborn screen does not catch every CF patient. It does not catch a lot of the minority groups. Recognize that we are going to miss African-American babies on the newborn screen. So do not assume that a normal newborn screen means there's no way they can have CF. I've had patients come in who've been told, well, your newborn screen was normal, and then we end up finding out they do have CF. So just be aware that there are also racial disparities in the newborn screening process. Every state is different as far as what mutations are included. So there are a little more of the mutations seen in the Hispanic population on the Texas newborn screen. So every state chooses which mutations are on their reflex. So that's my little newborn screen soapbox. Yes.
So on boards today, it seems like you would know that too, or should, like
If they'd said the newborn screen was normal.
Yeah.
So the challenge is this is a teenager. I don't think they're going to ask you that because newborn screens are instituted at in different years in different states. So I don't think they're going to give you that information because that's too tricky because of when CF newborn screening started. If they gave you a baby though, and they said the newborn screen was normal, I would not go down the CF path unless you think that's really, really what they're going at. Because take them at their word when they tell you in the STEM, something like that. They're purposefully telling you the newborn screen was normal so that you will know the newborn screen was normal. But I don't think they'd give you that in this situation. That would be a really poorly written question if they did. The other thing that you have to consider in patients with recurrent wet cough and pneumonia is primary ciliary dyskinesia. So this is very heterogeneous. We do not even know all the mutations that cause this disease. It is a recessive disease. Most commonly, and the reason we ask this in clinic on all our new patients is they may have respiratory distress at birth. So that's a high predictor for PCD, laterality defects, early onset year-round nasal congestion and wet cough. The challenge with this is that diagnosis is still a little bit difficult to achieve. So you can do nasal nitric oxide testing, but usually they have to be about 5 years old to be able to participate in that. You can do genetics, but the genetic panels that are out there don't catch everybody. So these kiddos can go on to get bronchiectasis. So you do want to treat their infections, but they don't have the pancreatic issues that CF patients have. So they do tend to grow well and don't have that same failure to thrive issue. Yes. So here is just kind of a picture of electron microscopy of the defects in PCD, and it's typically a dying arm problem. And so because of that, the cilia do not move the way they're supposed to because their ultrastructure is messed up. And so you have decreased ciliary movement. So you have mucus stasis in the airway. All right. All right, clinic, it is your turn on this question. 12-month-old boy is brought to the ER because of bluish discoloration of his skin. Mom noticed the child's lips turning blue 2 days ago. Lips and mucous membranes have become progressively blue and now involve fingernails and extremities. He's been acting normally, no cough, runny nose, shortness of breath, red mucous membranes, no rash. That's very poorly written. Just forget the mucous membranes comment. Sorry, I haven't looked at this in a while. He's a full-term infant who's been thriving. Shots are up to date, no allergies. He takes multivitamin drops, as needed doses of Tylenol and topical benzocaine for teething pain. Vital signs are normal except for pulse ox of 85%. Oral mucous membranes are moist and not erythematous, but have a blue discoloration. Breathing comfortably, lungs are clear, regular rate and rhythm, extremities are warm and well perfused, obvious cyanosis of the lips, nails, nail beds, and skin, no digital clubbing. What's the most likely cause of his cyanosis?
Hemoglobinemia.
Excellent. So remember that pulse ox looks at the saturation of hemoglobin. And so there's different light absorptions for oxyhemoglobin and deoxyhemoglobin. And with methemoglobinemia, you have the tighter bound, the iron doesn't release oxygen, it's just tightly bound. And so you are going to have issues with pulse ox not giving you a clear indicator. So always keep in mind to ask about teething gels. And I'm sure you guys ask that frequently, but parents still, even though there's been so much information in the media, parents still don't realize how risky those medications can be. So anytime you're seeing somebody with hypoxemia, this is a really, really helpful flow chart to have. So the alveolar arterial oxygen gradient is essentially whether or not oxygen is moving normally across the lungs. So if you have a normal gradient, but you're hypoventilating, you're going to have lower stats. If you have a widened gradient, so you have VQ mismatch, you have diffusion issues, you have a shunt, all of those things are also going to cause hypoxemia, but they don't all respond the same way to oxygen. So you know a shunt is not going to respond as well to oxygen because you're going to continue to have the combination, the movement of deoxygenated blood to mix with the oxygenated. But you should respond to oxygen if you're hypoventilating, if you are VQ mismatching, or if you have a diffusion issue. So, and if you've ever been in my office, like Liz and I are talking today, I have this in a little more detail on my wall. So if you ever care about knowing about causes of hypoxemia, I suggest you print out this chart. It's very helpful. All right, next question is for wards. You're the PCP for newborn twins born at 33 weeks, discharged from the NICU after 4-week stay. They needed oxygen for 3 days. Otherwise, very little respiratory support. They were diagnosed with reflux. They have occasional episodes of coughing and gagging, but no color change. They're otherwise well. Best advice to give the parents is what? Place them to sleep in the prone position, side sleep, sitting devices, sleep positioners to keep their heads elevated, or supine sleep.
Supine sleep position.
Thank you. This was not a trick question. All right, so briefly, they may ask you about SIDS on boards. Know that the occurrence peaks around 1 month of age and greatly decreases after 6 months. Risk factors, as you guys all know, are prone sleeping, co-sleeping, and recent infections. Decreased risks associated with supine sleeping using a pacifier and not having soft bedding. So there's this apnea theory that has been floating around as a cause of SIDS. It has never been proven. Apnea monitors do not prevent death. So just keep that in mind when you have kids who are coming home on an apnea monitor. And SIDS is not hereditary. I know there's been stories of families having multiple infant deaths. If that occurs, you need to consider child abuse. So the other thing kind of in this realm is apnea prematurity, and that is a central apnea. And that's one reason why a lot of babies who aren't going home on oxygen end up going home from the NICU with apnea monitors. Typically that will resolve by the time they hit 40 weeks. Sometimes it takes 42 to 44 weeks post-gestational age to completely go away. Treatment in the NICU could be caffeine. We very, very rarely, if ever, actually send or keep babies on caffeine. We don't ever put them on it in clinic. Some babies will actually respond to a little bit of low flow oxygen. That will probably not be on your boards, but just know that this should be gone by 40 weeks. Board question, should resolve by 40 weeks. Okay. Question 7 for the peanut gallery here in person. 9-year-old boy brought in because of snoring nightly that wakes his parents in the next room. He's been diagnosed with ADHD. He has witnessed apneic episodes followed by gasping and partial awakening. He's tired and difficult to awaken in the morning, has nocturnal enuresis, has not responded to bed alarms or liquid limitations. He's morbidly obese. BMI is greater than 98th percentile. Tonsils are 3+. He is sent for a sleep study, which reveals an apnea-hypopnea index of 30. Pulse oxidator is 70%. Patient is scheduled for tonsillectomy. Parents ask about the clinical relevance of their son's sleep apnea and the risks of tonsillectomy. You are most likely to tell them that A, ADHD is unrelated to sleep disordered breathing. B, nocturnal enuresis is unrelated to sleep disordered breathing. C, the patient is high risk for anesthesia-related complications and should be admitted to the ICU after the surgery. D, their son will not require continuous positive airway pressure as long as the tonsils are removed. Or E, tonsillectomy is expected to result in complete and long-term resolution of sleep disordered breathing. Yes, and we actually are just finished following a patient that had this situation occur after his tonsillectomy. So these kids are very high risk for post-obstructive pulmonary edema. So when you have long-standing obstruction, even if it's just at night, and you then remove that obstruction, you can get subsequent pulmonary edema afterwards that can be really significant. This particular kid, who I know several of you took care of up in the PICU, had a very bad sleep study and immediately postoperatively had pulmonary edema and respiratory distress and required BiPAP and came really close to getting intubated. So anybody who's going to undergo surgery like this with a really bad sleep study, so this kid has severe sleep apnea. I mean, an AHI of 30 is severe. He's got hypoxemia as well, and I would not be surprised if he's hypoventilating too. So know that severe sleep apnea, tonsillectomy, high risk for post-obstructive pulmonary edema and should be admitted postoperatively. Mm-hmm. Yeah. Mm-hmm. So abnormal is greater than 1, and then, yeah. So they're not making it difficult to know this kid has severe, yeah. You're not going to have to differentiate between moderate and severe. They're going to paint a very clear picture for you. So just really quickly, OSA, we are seeing more of it because of the increased rates of obesity. And you guys know this because y'all order a lot of sleep studies, but daytime sleepiness, hyperactivity, snoring, decreased school performance, all can be related directly to sleep apnea. So I do see some of that being a little bit worse with sleep apnea. It doesn't necessarily mean that fixing their OSA is going to fix the nocturnal enuresis, but definitely it's worth screening for if you have a kid that's really challenging to treat, or if it's an obese kid that already has this other risk factor if it's body habitus. Kids who have really high AHIs too are probably still going to need CPAP after their surgery. We repeat the study 6 to 8 weeks after the surgery. A lot of times these kids are going to require CPAP if they're obese and had a really high AHI. I don't know how many questions you're actually going to get on control of breathing on the boards, but it's possible that they could ask you about this. Know that there are different receptors, peripheral and central receptors. Both sets of receptors respond to carbon dioxide, only peripheral receptors respond to oxygen. So if you look at regulation of ventilation, you're going to have a much swifter response in your minute ventilation to changes in CO2 than to your arterial PO2. So if anything, you might have one question on this, so we're not going to belabor this point. All right, so clinic, you are next. You've been caring for an 8-year-old girl who was hospitalized with a right lower lobe pneumonia and pleural effusion. She came to the ER 4 days ago with a fever of 40.2, cough, moderate respiratory distress. She's continuing to require 2 liters of oxygen to maintain stats greater than 91% and persistently febrile. A chest tube was placed on admission, and exudative pleural fluid collection was confirmed. Her culture grew staph aureus. She has been treated with IV Vanc. She continues to have a persistent dense opacity and fluid collection in the right lung. Fibrinolytic therapy was instilled into the pleural space without resolution of the disease. Ultrasound reveals a complex and loculated fluid collection. What is the most appropriate next step?
So we're thinking that, so E.
Awesome. That is correct. So there is some debate over the best way to deal with these complex pneumonias, but the answer on the boards is going to be VATS. All right, we are not going to talk too much about this, so we can keep going. Probably. I don't think they're going to ask you that specific of questions. I think that if they're going to, I do not think they're going to ask you to choose between fibrinolytic therapy and VATS. That would not be an appropriate question, because that's what there's debate over, is whether you try fibrinolytic therapy or go directly to VATS. Okay, you do need to know the difference between a transudate and exudate as far as pleural effusions. Honestly, this is easiest to write down and look at the night before. But if you can keep kind of a general idea that transudate is mostly just fluid, whereas exudate is going to have other cells in it. I don't know that they're going to ask you to calculate the ratios, but if you know the ratios, it's going to be easier to just look at the question and tell the difference. But you will need to know the difference. And I can send you guys these slides too afterwards if you'd like them. Okay, so next question for the team here. 14-year-old adolescent brought to the ER with complaints of shortness of breath and moderately severe sharp chest and shoulder pain after he was hit by a teammate during football practice. He has a history of mild persistent asthma, seasonal allergies, which are both well controlled. Well-developed, well-nourished adolescent in mild respiratory distress. He appears slightly splinted in his respiratory effort because of chest pain, and he's anxious. Respiratory rate is 30. Oxygen saturation is 94. Cardiac exam is remarkable for mild tachycardia. Lungs reveal moderate aeration, clear without wheezing, crackles, or asymmetry. Subcutaneous crepitus is demonstrated at the shoulders, neck, and jawline. Normal abdominal exam, normal extremities. Chest X-ray is here. All right. What is the answer? Correct. Could everybody see the pneumomediastinum on the chest X-ray? Okay. Any questions about that for those of you who are virtual? Okay. Yeah. From the crepitus is really the key. I think that yes, but it might have been a lot harder question. Yeah. But they're not going to be able to see mine.
Can you see the air in the neck? Yeah. The black lines, that's the air in the neck. You can actually see it kind of where the aortic knob is, right there on the right side. That.
I would never see that.
Yeah, I see the neck. But the neck, I think, is the most helpful in this situation. Okay. All right. So also be familiar with spontaneous pneumothorax. This tends to occur in male smokers, but not always smokers. I've seen it multiple times in males who are not smokers, who are super tall and thin. Some of them have blebs in the airway, some of them don't. But know that this can happen spontaneously, both a lot of times in teenagers, but can occur in infants too after delivery. So just be aware of that diagnosis. If it's a teenager and they're a smoker, you want to make sure that you talk to them about the risks of continuing smoking and that they can have repeat pneumothorax. You don't want anybody with a spontaneous pneumo or any pneumo to fly within a week of full resolution of the pneumothorax. You also want to be very careful with these patients if they ever, even after a resolution of the pneumo, to do any deep sea diving, scuba diving, or flying an unpressurized aircraft. So if they've not had pleurodesis, which essentially scars the lung down, anyone who goes to those in those pressure change situations is at risk for a repeat pneumothorax. So just be thoughtful about that. There are a couple of kids in the community who have recurrent pneumothoraces who, if you were their PCP, you want to be sure to advise them about, like if they were taking flying lessons or something in an unpressurized, like little jumper plane or scuba diving. Mm-hmm. Mm-hmm. Yep. With recurrence, it may be pleurodesis. If they are not resolving quickly, a lot of times they do end up needing a chest tube to reinflate. Okay, we've got 14. Okay, we're gonna go through these quickly. I'm gonna have just the group here in person shout out answers so we can go through the last 4 questions quickly. So you have a newborn in the delivery room, born to a 26-year-old, no prenatal care. Mom was previously GBS positive. APGAR scores are 1 and 4. Baby's in acute respiratory distress. Bag mask ventilation is in progress. Baby's cyanotic, poor tone, little respiratory effort. You intubate and provide positive pressure ventilation. When you listen, you have asymmetric aeration, primarily right-sided breath sounds. Needle thoracostomy of the left chest returns no air. Abdomen is distended and tympanitic to percussion. OG tube is placed. What's the most likely etiology? Yeah. So this kiddo, you are blowing up the intestines that are in the chest with that positive pressure ventilation. So that is why things kind of start to get worse and worse, why the belly is, what's left in the belly is getting blown up, what's in the chest where you're not hearing lung sounds is also getting blown up with air, because with the positive pressure ventilation, you're also blowing it into the GI tract. So any baby without prenatal, especially without prenatal care, who comes in with only breath sounds on one side in significant distress and looks hyperexpanded, the belly is kind of bloated, and you may even hear bowel sounds, maybe on that side, think about CDH. And this happens every once in a while. We've had one in the last couple of years here, at least one, if not 2, babies with undiagnosed CDH that we caught at birth. Questions about that? Okay. Next question, 7-month-old brought to your office for a follow-up, recently hospitalized for the 3rd time with bronchiolitis. Every time she's been treated with short-acting beta agonist and systemic steroids. No history for pneumonia or ear infections, full term at birth. Parents said that they have heard whistling and rattling in their infant's chest since 1 week of age. She has reflux and has been treated with ranitidine. You note a thriving infant and no distress. Comfortable respiratory pattern, but slightly tachypnic at 48 breaths per minute. You note a monophonic coarse wheeze, which is more notable at the left chest. The remainder of the exam is unremarkable. You review the most recent chest radiograph and recognize a double aortic arch. What do you do to confirm your suspected diagnosis? Yeah. This is where you want your CTA. Questions about that? Any concern for vascular anomaly, you really need to confirm with CT with contrast.
What is the double?
That there could be some other vascular issues that are compressing the airway and causing the wheeze. Yeah. And it may just be the double aortic arch that's impacting the airway, but you want to make sure you don't have any other rings or slings. Okay. So this is just kind of a list of potential developmental issues with the lungs. I don't think you're going to get a ton of questions about these. These are very specific. Know they exist. So if you see them in a question, you'll be like, somebody's making this up. But I don't expect you to get nitty-gritty questions about any of these. These aren't pulmonary boards. This will just go through really quickly, and I'll send you these slides too. But you can have things such as congenital pulmonary airway malformations. They can be pretty large. You can see, which you can see here. So see these really large air-filled spaces without lung tissue. That's a congenital malformation. Bronchogenic cysts typically are more closer to the midline. We've had kids come in with a bronchogenic cyst that was sitting below the carina and was pressing up on the airway, and he'd been treated for asthma for years. Dr. Dan finally saw him, sent him for imaging, and they found the bronchogenic cyst. Congenital lobar emphysema may initially look consolidated on an x-ray before it starts looking more aerated. Sequestrations often are misdiagnosed as recurrent pneumonias. They have their own vascular supply, which makes CT with contrast really helpful. You might see this consolidation here, but the radiologist will be able to trace a vessel to it and be able to help you figure out that that's not a pneumonia, but actually a sequestration. So this is just a really nice chart looking at the different vascular rings. So to your question, Dalton, the double aortic arch, this is kind of what the anatomy looks like. So you may have compression of the airway. And then remember we talked about the barium swallow before and how that can be used to look at vascular compression. This second column of pictures shows you what you would see on a barium swallow on these different types of vascular anomalies. You won't need to know those patterns, just know that a barium swallow can show you abnormalities from vascular rings. No. Just know that you can have compression with vascular rings that can give wheezing. Know that a barium swallow can be helpful in diagnosing it. And then also know that CT with contrast would be your other diagnostic modality. Yeah. Not practically, no. Practically, you go straight to the CT. I don't think they're going to ask you barium swallow versus CT on boards. You just need to know that you can see changes on a barium swallow with vascular rings. Yeah. They're not going to ask you to choose between one or the other. Okay. Question 12 might have to be our last question. 14-year-old brought to the ED with 2 months of intermittent wet cough. She's had 2 to 3 episodes of blood tinged sputum and a month of increasing fatigue and pallor, increasingly intolerant of physical activity, and now experiences shortness of breath when climbing 1 flight of stairs. Today, she had a fainting episode and was brought to the ER. Mom reports several months history of rash on her nose and cheeks, as well as decreased range of motion with swelling in her fingers and wrists. Recently, her urine has looked like tea. On exam, she has regained consciousness, ill appearing with moderate respiratory distress. She's tachycardic and tachypnic with labored breathing. Blood pressure is 90/60. Sats are 92. Oropharynx and nares are clear without blood. Mucous membranes are pale but moist. Lungs have diffuse polyphonic wheezing with decreased breath sounds at the bases, scattered fine crackles. Cardiac and abdominal exams are normal with the exception of tachycardia. Brisk cap refill, extremities are warm, no clubbing, hemoglobin is 5.9. Of the following, the most likely etiology of this patient's hemoptysis is what? Yeah. This is her chest x-ray, which I don't think is super helpful. So you need to know the causes of pulmonary hemorrhage. Most commonly is infection. So typically if there's blood in the airway, it's infection. Sometimes people will complain of hemoptysis if it's epistaxis and it's posterior epistaxis. And so it'll drain down and they'll cough it up. Boards is not going to call that hemoptysis, but in real life, know that there is an entity called diffuse alveolar hemorrhage that can be caused by a number of things, including quite a few rheumatologic diseases, pulmonary capillaritis. If you were on boards recently, EVALI has caused that in a couple of patients. That will probably not be on your boards. Pulmonary hypertension at times has caused hemoptysis, AV malformations, and then coagulation disorders and whatnot. But number 1 cause of hemoptysis is infection. Number 2, you have to think about vasculitis and other issues lower in the lungs. Okay, we're gonna have to wrap it up because I have a patient, but I think there's only 2 questions left. I'm gonna send you guys these slides so that you can take a look at them. And if you have questions about anything we've talked about, these last 2. Yeah. There's only one more, sorry. And you guys have heard me talk ad nauseum about pulmonary hypertension. If you have questions about that, let me know. There's the information in these slides is probably a little more than you actually need to understand. But you do need to know in pulmonary hypertension that high CO2, low SATs, atelectasis all can make pulmonary hypertension worse. So those are things that you may be in a position to control as a provider with these kids. And that's it. All right, y'all. Yeah. All right, I'm going to send these slides to the 3rd year class, but if anyone else wants them from any of the other classes, just shoot me an email. Thanks, guys.